Welcome to the January AAC Promising Practices webinar, Addressing Addiction on a Community-Wide Level. I'm Rebecca Trout, and I am the Director of the All-America City Award Program here at the National Civic League. The National Civic League will be celebrating our 125th anniversary this year. We're a nonprofit that aims to advance civic engagement to create equitable and thriving communities. The All-America City Award is our flagship program, and it began in 1949 to recognize exceptional civic engagement in local government. The 2019 All-America City Award theme is creating healthy communities through inclusive civic engagement. We are looking for projects that demonstrate inclusive decision-making processes to create healthy communities for all, and particularly for populations currently experiencing poorer health outcomes. If you're interested in applying, applications are due March 6th. And I'm happy to answer any questions you may have about the process. While AAC celebrates great work, we also aim to share the innovative practices, initiatives, and projects around the country through avenues such as this monthly webinar series. Today, we will be learning about how two communities address addiction. First, we have Judge Julie Britton and Kevin Boone, who will be discussing Beaverton, Oregon's B-SOBR program. Following B-SOBR's program, we will be joined by Police Chief Thomas Sinan and Sonia Carrico, members of the Hamilton County Heroin Coalition. If you have any questions during either presentation, please submit them via the chat box, and we'll have the presenters answer them at the end of the webinar. Julie and Kevin, the floor is yours.
Thank you. Appreciate that. Just want to get the mechanics here 1 sec. So let me get us up to our screen that we want to go to, and I apologize. My name's Kevin Boone, and I am the B-SOBR Court Coordinator, which is a specialty court aimed at repeat DUI offenders. I'm also here with presiding Judge Juliet Britton from the court. And we want to just talk about our program a little bit, and we'll go from there. Next slide we have here is our bios. Everyone can read those exciting things. Currently we have, it says 43 participants in our program. We actually took a 44th in yesterday afternoon. Our program's been in existence since 2008. We've had 106 participants that have successfully completed our program. And a great statistic that we have is that DUI recidivism rate is less than 5% for the graduates of our program, which is dramatically less than a repeat DUI offender who would have a recidivism rate of probably 30 to 40%, meaning that they would be driving under the influence of alcohol and or drugs again. Why DUI courts? DUI courts, they're problem-solving courts dedicated to changing the behaviors of DUI offenders with the goal of protecting public safety by using an adult drug court model to address the root cause of impaired driving, which is alcohol and other substance abuse. These offenders engage in very dangerous behaviors that absolutely endanger everyone in your community. So just some sobering statistics. 2017, there was a little over 37,000 vehicle deaths in the United States. Of those 37,000, roughly 30%, 29% had a blood alcohol level above 0.08, which is the legal limit throughout 49 states now. Utah just changed theirs, lowering their blood alcohol level to 0.05, and they did that on New Year's Eve of last year here. And we're debating it, starting the debate in our state. Just as important is the next statistics there with vehicle deaths with the blood alcohol level above a 0.15, where we have 7,368 deaths. All the statistics show as that blood alcohol level rises and starts to get above 0.15 and greater, much more likely there's going to be an accident and that there is going to be a fatality. Last stats there, blood alcohol level 0.15 or higher in fatal crashes are 9 times more likely to have a prior conviction for driving while impaired. Typically, most people, if they're driving with a high alcohol level, they're really not driving. They're probably passed out asleep somewhere because they can't drive, because that's the effect that alcohol would have on somebody if they didn't have a high tolerance level. As for drug driving, 20% of DUIs driving under the influence of intoxicants, 20% show up as some other kind of medication, prescription or over-the-counter medication. That statistic probably is actually low, because when your typical DUI driver is pulled over, they're given a breathalyzer test, which measures blood alcohol level. If they register positive at a certain level, there's no more testing that's done. They just accept that. If they were given a blood test, have a blood test and run that for drugs, almost 100% of those people end up having drugs in addition to alcohol in their system. And it's just, most people that are driving drunk really probably aren't, a good percentage are not just using alcohol. I'm going to just turn it over to Judge Britton so she can talk for a few minutes here just about kind of like typical stuff going on.
So the city has really taken a multidisciplinary approach to addressing DUIs in our city. It is the #1 crime in our municipal court. So more people are arrested for DUI than any other crime. So we work collaboratively with our local law enforcement, as well as our county law enforcement, as well as our state level safety programs. So we have the Oregon Department of Transportation that funds DUI safety programs. So they provide funding to local law enforcement to do specific DUI enforcement details throughout the year, particularly when we know that certain holidays or certain times of the year are likely to have an increase in impaired drivers on the road. We also have our local law enforcement commitment from our chief, who regularly sends our police department officers to trainings on DUI investigations. I can tell you the cutting edge area is the DUIs that include not just alcohol, but the drug DUIs. That's where a lot of the cutting edge investigatory techniques are happening, both in law enforcement as well as in the courts. So on the front end, there's a lot of safety strategies listed here with other departments. By the time somebody is arrested and charged with DUI, that's really where our program comes into play further down the chain, if you will. So in a traditional DUI case, if you've had multiple DUIs, you know, in Oregon, not until you have your 4th or 3rd DUI are you actually going to, is it going to be charged as a felony. So multiple DUIs in Oregon still are considered misdemeanors. Typically, you're going to plead to a traditional probation term, usually maybe 2 to 3 years. You might do a couple days in jail. And in municipal court, we don't have probation officers, so there's no formal probation. You would basically be doing your alcohol treatment, your victim impact panel, and paying your fines off with very little continuing monitoring of your sobriety, for example, once treatment ends. And in Oregon, sadly, the typical alcohol treatment program is only about 90 days, where there is drug testing, urinalysis testing, but typically there's not any urinalysis testing after that. And what we find on those cases, if you're a high-risk, high-needs individual, that probation model is insufficient to keep you from committing a new crime. And so that's why the city developed the B-SOBR program to have a more formal structure that we'll talk about in a little bit.
So talking about that recidivism piece there, so I'm not sure how many of you are aware, but basically if you took 10 DUI offenders and you put them in a room, you could have 3 of them raise their hand. Those 30% will be offending again. Statistics throughout the United States bear that out. So those are who we are addressing. Why is it, do those people have a problem? Why are they having another arrest? It's not that they haven't been given the same tools as other people, but 70% of the people who get a DUI, that's a life-altering experience. Their first altercation with the law, they say, I cannot do this. This is absolutely wrong on so many different levels. That 30%, statistics again bear out, they have addiction issues. Why can't people just change? Nancy Reagan, her famous saying, just say no, it's not that simple. Addiction is a disease of the brain which affects decision-making. So it's your decision-making part of your brain, your prefrontal cortex is disengaged through the use of drug and alcohol, and you're getting into the mid-level of your brain, which is a whole different decision-making process that's being made. So it's much easier for someone who has an addiction problem to continue to use than to change. So what we're trying to do is change these behaviors using this drug court model, evidence-based practices. We focus on what's called 10 key components of drug courts, 10 guiding principles of DUI courts. Generally, here's just 10 key components. You're integrating treatment into the justice. You have a non-adversarial approach. You're identifying who these individuals are. You make sure you hook them up with services that they need and get them on a continual basis in those services. A lot of drug screens going on, which is ensuring sobriety. You have a whole lot of coordinated strategy of responses to different behaviors, good and bad, that participants can have. There's judicial interaction in a different fashion than your typical court. You have program evaluations, continuing education of all the different people on the team, and building a lot of partnerships and collaboration. Guiding principles of a DUI court, we target the population, we provide a clinical assessment, develop a treatment plan, supervise, detect behaviors, look at partnerships. There's an active judicial role, a lot of case management, look at transportation. So we're going to look at these a little bit more. So in targeting the population, we're focusing on people that are high risk, high need DUI offenders. With high risk, meaning that someone's at a higher risk for another DUI offense, and they need more intensive supervision and services. The higher need principle maintains that there's dynamic risk factors that are most associated with this criminal behavior, and those should be addressed. And absolutely, positively, driving under the influence of alcohol and or drugs is a criminal action. Again, targeting the population, we're trying to get people quickly into the program. We want to get it, that basically has them immediately addressing their problem. It reduces recidivism 63%. When people go into treatment court and allowing non-drug charges, that reduces recidivism 95%, has a cost savings of 30%. Treatment plan, absolutely, we're working with treatment. Getting a contract, you try to specialize with 1 or 2 providers. This actually reduces recidivism 80%, has a cost savings of 12%. I know we're running, we've got about 7 minutes left, it looks like. I just want to make sure we get through some other stuff here. We have a lot of supervision and detecting behavior, so we have a lot of drug tests. They're basically done at least twice a week on a random basis. This is getting people to recognize that they can be clean and sober and start to change. You cannot change somebody if they are still under the active influence of alcohol or drugs. Doing this, again, lowers recidivism, and it has a cost savings to the community of 61%. Getting drug screens back immediately, again, it gives us the ability to have conversations with the participants, good and bad, as to whether they're using drugs or supporting them in their positive behaviors. So it's a great thing.
One of our important factors when we were developing or deciding whether we wanted to explore a specialty court was the recognition that you do need buy-in from everyone involved in the criminal justice system. And so what the city did was they convened a multidisciplinary partner meeting, if you will, and inquired whether or not we had the buy-in from the prosecutor, from the defense attorneys, as well as law enforcement. In our case, again, because we're a municipal court, we don't have access to the county probation supervision services. And so we had to get the buy-in of our chief that he would provide multiple police officers to assist us with our traditional probation officer supervision. And so what that looks like in our model is it's local police officers who do home visits and check in with some of our participants.
And the slide's just basically showing again how developing these partnerships, especially with treatment, actually how it reduces recidivism and has cost savings for the community.
So from a judge perspective, you know, I have been practicing law for 20 years. The big difference as far as the role the judge plays on any sort of specialty treatment court is that it's a non-adversarial role. So our participants are appearing in court as a group twice a month, and depending on which phase they're in, and basically doing a check-in with me. Best practices says 3 to 7 minutes I should be spending with each participant. And, you know, our motto is show up, try, and be honest. And in response, this multidisciplinary team of case managers, treatment providers, defense attorneys, prosecutors, and the judge, we're all going to assist these participants as they move through, whether they have high points, we celebrate their successes, and also when they have low points, such as relapses. And so the interactions with the judge are not confrontational at these check-in sessions. It has a feel more of like an AA meeting more than a typical judge interaction. We do reserve probation violation hearings on a different separate docket day, which of course is a little more adversarial.
A lot of case management goes on. Absolutely, we have a specific individual that's a case manager. To complete the program, they at least have to have a minimum of 90-day sobriety. That reduces recidivism right there, 164%. Jail sentences down on the bottom there, greater than 6 days, have a higher recidivism rate. You no longer are treating somebody, you're now punishing them. And what these individual needs is treatment. They don't need more jail time if you want them to change.
One of our biggest advocates is the jail commander. They're one of our allies because they like that statistic.
Moving along, it's important to evaluate the program, have someone, you know, come in, take a look at what is going on and what's working and what's not working. Review that with the team, and then we can start making adjustments from that point. Absolutely. And then back to ensuring sustainability, we need to make sure that all new team members, they get training, they get orientation, all this kind of stuff. So we're all coming at this approach the same way. And kind of wrapping up here real quickly, this is basically fidelity to the model. One of the big leading voices, that's his model, is fidelity to the model. And basically DUI Courts work because it reduces recidivism up to 60%, treats the root cause of addiction, makes for a safer community, and saves $3.19 for every dollar invested. So it's if you do all this stuff that they ask, and kind of rather than just thinking you know yourself what should be done, you can have a lot more success. We've attached a list of some resources for where you can go out and online, look at all sorts of different things, and so this would be some great ones here. The last one down there is B-SOBR videos. If you want to go on and see some videos and see some participants talking about our program, we have 2 videos that are at that on our City Council website. You can take a look at those. And then lastly, most importantly, you may say, hey, how do we afford this? Well, grants is important, absolutely. Substance Abuse Mental Health Service Administration, that's SAMHSA. Go online there. They have all sorts of grants for all sorts of different things, not just for DUI courts. National Highway Traffic Safety Administration, they have a whole lot of grants for all sorts of safety on the road. Talk to your State Department of Transportation. So ODOT, Oregon Department of Transportation, has funded our case manager position for 7 years. Absolutely. Look at your state criminal justice department. They'll have state grants for the same kind of thing. So with that, I think we're going to wrap it up and turn it over to you, Rebecca.
Wonderful. Well, thank you so much, Beaverton, for sharing and explaining your very effective program. Really appreciate your time. A couple of questions that came in while you were speaking, and we will get to those at the end of the webinar. And for all of you on the call, please remember to submit your questions through the chat. And but in the meantime, we are going to go ahead and hand it over to the folks at Hamilton County. Chief Synan and Sonia, the court is now yours.
Okay, thank you. We're pulling up the slides now.
Good morning. Thank you for inviting us. I'm Sonia Carrico, the Senior Program Officer for the opioid team here at Interact for Health. And Chief Synan is here with me as well, who has been actively involved in the Hamilton County Heroin Coalition. Interact for Health is a philanthropic organization serving the greater Cincinnati area, focused on reducing tobacco use, Tobacco 21, expanding school-based health care centers across our region, and then, of course, addressing the opioid issue within our region. My focus is to try to bring together the 20 counties in our service area to have a much broader regional approach that can become more sustainable over time. And we're doing that by bringing in all of our community partners across the 20 counties, which does serve a tri-state area, and allowing them to develop the priorities that they want to focus on in their communities. And we're really going to be approaching it from a what we're doing well perspective. So there won't be as much time spent on what we don't have or what the gaps are, because we do have a lot of successful programs and services in our region, but our focus will be on how do we grow those out? How do we plan for sustainability over the long term to address addiction issues across our region? Some past accomplishments that we have had, including the ability to saturate naloxone throughout Hamilton County, developing the first syringe services program here in Hamilton County. We also pulled together a group of private philanthropic funders who are supporting quick response teams as well as stigma messaging in our area. And then about 3 years ago, Interact was fundamental in helping the counties that are identified above put together very specific opioid response programs for their communities. We funded a lot of programs focused around prevention, life skills, more of the social emotional learning work, as opposed to just the traditional prevention work of these are why drugs are bad. We've also helped communities set up permanent safe medication disposal sites, be it at law enforcement centers, pharmacists. We've worked with the Ohio State University to implement Generation RX across our region as well. And we continue to work on the Narcan Distribution Collaborative. We have expanded the syringe services program outside of Hamilton County into neighboring counties. And the quick response teams have also grown outside of Hamilton County and are now reaching out into our neighboring counties as well. You'll see we worked with a software company, Core Data, in order to begin gathering data and tracking outcomes around the efforts of our quick response teams. Interact did develop a strategic 5-year plan. We are currently in year 2 of that plan. Our very broad goal is to reduce the trends in overdoses and deaths from opioids, but we realize that the work that we will be doing with our community partners will be addressing addiction issues as a whole. We are seeing a resurgence in crystal meth within our community. Obviously, alcohol and tobacco are always prevalent, and we are starting to feel pressures from our neighboring states with regard to medical marijuana and the threat of marijuana recreational legalization. We do base our work on data, and we want to be grounded in evidence. We are fortunate to have an evaluation team here at Interact, so any of the funding work that we do does have an evaluation component to it. The work that we'll be doing across our region with our regional coalition partners will be developed around best practices and how we expand those, how do we maintain fidelity with our best practices, and where we have opportunities, we also hope to develop new best practices to meet the needs of our communities. I'm going to wrap up here with just a quote that I always keep in mind and I share with our communities, and that is, if we're not keeping score, it's just practice. Came from a former governor that I worked with. So it's important to us that we're documenting our successes so that we can in turn share our success. And it does help us build that capacity and sustainability across the life of the work that we're doing and beyond the work that we're doing here in our communities. With that, I'll turn it over to Chief Synan.
Hello, everyone. Thanks for having me. My name is Chief Tom Synan. Just to give you a real quick idea, I'm the police chief of a very small community, about 3,900 residents, about 11 miles east of downtown Cincinnati. I got involved, and it's kind of strange a small town would be involved in such an issue like this, but I got involved after watching an entire family die from addiction, the mother from abusing prescription pills and alcohol, and all 3 of her sons were killed by addiction. 1 was shot and killed by crack cocaine, and the last 2 overdosed on heroin. So this truly is a community response, and the thought behind it was that me as a small town, I don't have a lot of people necessarily dealing drugs within my community. It was obviously in the bigger cities, which the closest one does was Cincinnati. And in turn, not everyone is selling drugs in the city of Cincinnati is using. So my members, some of my members of my community were buying the drugs in Cincinnati, and some of the drug dealing was being done there. So the thought and the concept, and you'll see a lot of overlap, especially with Interact for Health, was that we need to take this on as a community response. It's strange because we in local government and within the systems, we recognize these borders, yet no one else does. The drug dealers don't, and those using drugs don't recognize those borders. So it's actually Interact for Health that had a community plan. And traveling across the country, you see pretty much kind of the same thing, the 4 pillars, and sometimes people will add different pillars to them. Interdiction, treatment, harm reduction, and prevention. So we took the plan with Interact for Health, and what we've got, some of the good things we have going on here, is we have strong police associations. So our communities work really well together, and also the local governments from the county and local governments, all the jurisdictions. We have about 47 different jurisdictions within the county. So we actually work really well together, and what ended up happening was after Interact for Health designed this plan, the Hamilton County Commissioner's Office and the county administrator back then, Christian Sigmund, took this on, and we worked with them, and we brought together community members, and we looked at this from a true community response. And at the time when we started this, we were calling it an epidemic, and we were dealing with anywhere from 20 to 25 overdoses a week within Hamilton County, which includes the city of Cincinnati. So that 20 to 25 was all the 47 different agencies, including the city of Cincinnati. But in the week of 2016, of August 19th through the 27th, that's what I call the literal transition from the organic opiate of heroin to the synthetics of fentanyl and carfentanil. That year, we transitioned to 50 to 70 overdoses with 4 to 5 deaths a week. We are now down from 2017 a little bit, so we're averaging about 40 to 50. But obviously, as you can see, that is overwhelming numbers, and it doesn't matter how big of a community you are, you're overwhelmed. So even in my small community, after a family died, we were still dealing with other people that were overdosing. But the city of Cincinnati was dealing with the brunt of this, and it was overwhelming our resources from every level. So we took a community approach to this. And it started off with 9 members of the steering committee, about 9 members. The important thing about that steering committee, and I think what made us more successful in getting this off the ground quicker, was that we used the heads of each agency. So it is everything from law enforcement. I represented the Hamilton County Police Chiefs Association. We had the county commissioners. It's the head of prevention first, the head of mental health and addictive services. It is the health commissioners, both from the county and city. And that made a huge difference because those were the people that could say yes or no to doing something, but they were also the people that you talked to directly when you needed a resource. And what it really did, and I hear this when I go across the country, people talk about tearing down silos. I don't agree with tearing down silos. What I believe is that people should stay in their silos, but they should have a front door and a back door. And what we should be doing is we all should have access to that front and back door and share our expertise. There's people within the treatment world that are experts. There's people within the prevention world that's experts. I, as the police chief, as law enforcement, should be able to walk into those silos, learn from them, and then take that back to the street. But I also should link my ideas and what I'm seeing on the street back to them. So this coalition has now grown to about 100, roundabout number, about 100 groups, people, community advocates, and it is everyone that's on this list. From hospitals, again, Interact for Health had an original plan, but now we have strong grassroots efforts within the community. We're seeing a lot of religious groups come up. I was thinking about this today. One of the groups that we had trouble getting on board at first, but is now one of the strongest advocates we have, is really the business community. And I was telling a story when Christian Sigma was still here. We had a little bit of a challenge trying to get the business on board because of the stigma attached to it. It was difficult for a business to come on and say, yeah, I want to help with the opiate epidemic. But now, since we have this coalition and a strong group of people and so many people involved, and we're kind of changing the discussion, now it's the business group that is helping with funding. We presented to a business group that helps with grant money, and they ended up approving a grant through the state, helping us with it, that allows for treatment, including medically assisted treatment in the jail. So that's a significant shift, and the business community coming on board was really important. As you can see, what really changed was the numbers. The numbers forced us to change how we approach this. And you hear this all the time from law enforcement is we cannot arrest our way out of this. And I'm proud that it's been law enforcement that's been some of the ones on the forefront of this change. Interact had this plan, but when we're talking about quick response teams, pre-arrest diversion, when we're talking about task force or changing the image or stigma or getting the jail involved, it's really law enforcement who has stood up and said, we need to do this differently. We can't handle the numbers. There's many people that are being impacted. And what we found was it's not always just addiction. There was a mental health component to this, domestic violence, poverty, education. There were a lot of social issues that were wrapped around this that often in law enforcement we're tasked with or taking on this burden of trying to solve these issues, but we're not the experts. And again, I go back to the silos. That's why those silos were important. Is because if I, as a law enforcement officer, can go to an overdose but find out there's transportation issues, there's child care issues, there's social issues involved in it, hopefully I can walk through the front door of those experts, those silos, tell them the needs, and then they can come back and get us the resources we need. What the goal would be is, can we allow law enforcement to be the link to these many other services? And listening to the court presentation before, the courts are very important in that. Not only we have drug courts, we have certain specific courts, but they're important too because now we can take it from not just the criminal justice side, but they're putting people in treatment also. And we're working on pre-arrest diversion. We're working on some things that not only with the court, but can we divert people out of the criminal justice system? Like I was talking about before, if someone's sitting in jail, they're obviously not getting the care they need. Can we get them into the care they need along with long-term support, peer mentoring? Can we get them into recovery? And what we're working on is long-term housing, which I'll show you at the back end of it. But one of the first things we wanted to do was, number one, was save lives. So Narcan was extremely important. We worked with the Hamilton County Health Commissioner, and we gave every police officer in the Hamilton County region, including the 47 different jurisdictions, the ability to have Narcan. So City of Cincinnati, all 700, 800 of their officers that are on the street have Narcan, have used it. My officers in my small community have used it almost a dozen times. So having that Narcan on the street with those first responders, even before the fire can get there, made a huge difference, especially when we transitioned into the synthetics of fentanyl and carfentanil, because we found the Narcan we used was not enough and we needed more. So we've been able to be flexible with that intelligence from the street, pass it on to those different groups, community groups, health department, hospitals, and then we come up with a community response with it. But one of the other things we needed to do was collect data. We didn't necessarily know where people were overdosing. We didn't necessarily know the demographics, so we needed to come up with a data program. We actually have different groups that are doing data, but one of the main groups that we use is the Hamilton County Health Department. And they're going off of 911 dispatches and also ER visits. And what we do with this data is on a daily basis, we're monitoring this. If we see a trend that kicks up, we'll put out a health alert to the entire region, the entire community. A lot of other communities are now using this from Columbus, Cleveland, Pennsylvania, because we find that drugs kind of go in a trend. Working with the University of Cincinnati, we found that what happened in Hamilton County, 6 days later would go out to the eastern counties in Ohio. So now we're sharing this information with not just within our county, but also within the entire region. What we've been able to do is, you see a map of Hamilton County, which borders northern Kentucky and also Indiana. The very red spots are where we see the most overdoses. Originally, when we looked at this map, we thought it was the residents of those communities that were overdosing. But what we found is about 25% of the people overdosing are from other areas. They're either from Indiana or they're from Kentucky. Obviously, Cincinnati being it's the third largest city in Ohio, it is a major hub along with Dayton, Columbus, Cleveland. Generally, what you find is your drug dealing is going to be within those kind of areas, and you're going to have people coming into those regions to use drugs. What was different about opiates and what really transitioned for us for law enforcement was, unlike other drugs where someone may buy it and go home and use it, the people going through the withdrawals needed that drug right away. So what we were finding is these hotspots were not only areas where people were dealing drugs, but also people were using them immediately and overdosing. So that gave us intelligence that now we can put resources in, like Sonia talked about, when we're talking about syringe exchanges, when we're talking about hepatitis C, HIV care, we're talking about getting health departments in or treatment in. Now those red spots are where we're sending a lot of social services into those areas. Can we work on the demand side while we're also saturating with the law enforcement side? Can we work on both the supply and demand? What we're trying to do, and I'll finish up here so we can make sure we answer the questions that you may have. What we're trying to do is this community response is, we want interdiction from the very first point to be able to connect into one of these areas. It either is going to be a court probate under Casey's Law, which Casey's Law is in northern Kentucky, or Kentucky is a state, and basically allows a family member to probate somebody into treatment. We're actually exploring that type of thing here in Ohio, or what would civil commitment look on our end? Civil commitment, getting people out of jails, getting them into treatment, getting them longer-term care. Criminal court or drug court, can we refer some of those low-level drug offenders or those that are addicted from the criminal court into a drug court or specific courts like that again require that treatment and work with other social service programs? Then, or can we do pre-arrest diversion and get them into treatment? We now recently have from federal funding what we call an engagement center. So now those quick response teams are able to take someone, have them reviewed by a doctor, take them into an engagement center. They start medically assisted treatment, then they're referred out to other treatment facilities. One of the exciting things we've had recently was a hospital system stepped up. It is now treating addiction as if it was a chronic condition like anything else. We've kind of taken this attitude in our area that we view addiction as a chronic mental condition, like any other chronic illness, like any other chronic medical condition. It needs mental and medical health treatment instead of just law enforcement or punishment, as was mentioned before. Then can it get into that longer-term care? And from that longer-term care, we actually have 3 businesses that will hire people who recover or are out of treatment. And they understand that addiction is a chronic condition. On average, 7 to 8 times for someone to make it through treatment, 1 to 3 years for the brain to be rewired. Those businesses understand the relapse portion of this. They say that if someone relapses, as long as you get back into treatment, we'll hold your position for you. When you get through your treatment, you can get your job back. So we have all the pieces. Some of the hurdles we're facing are the same hurdles you face everywhere. Number one is stigma. The public stigma is part of the issue, and it's a stigma because, as a cop, I got to tell you, the biggest reason we have stigma is because addiction is a crime. You possess a drug, you use a drug, it's considered a crime. As long as we have that, we're going to have that stigma. But what we found working with these groups and these collaborations was that there was stigma within those organizations. Law enforcement had stigma, and we're still trying to deal with, are we law enforcement or first responders? The medical community had stigma. The business community had stigma. And some of the campaign that we're working on with Interact for Health is one of the major things is, can we change that stigma? Can we educate, bring more awareness? And then obviously one of the other hurdles we face is funding. Funding is always an issue, and we're talking about grants. Those are usually going for about 1 to 2 years. So if we're talking about this infrastructure like you see up here on the slide, how would that be paid for long term is what we're looking at now. What would recovery look? What would the entire system look like? We have the pieces. Can we connect it all together? And then can we make sure that we build a foundation and a system that not only treats opiate addiction, but addiction as a whole? So that will end it for Sonia and I. I'll take it back to the moderator and see what we do from here.
Wonderful. Thank you guys so much for your presentation. Really appreciate you taking the time to share that with us. We do have quite a few questions here coming in. So we'll start with those first. First on the docket is going to actually be addressed to the folks at Beaverton. The question is, has there been a change in the program with the legalization of marijuana?
No, there hasn't. It's a program that addresses, in the state of Oregon, we have what's called the DUI, driving under the influence of intoxicants. So the fact that someone could go, and actually recreational marijuana is legal here in the state. The fact that someone can go and buy marijuana and smoke it legally in the state has no saying, no meaning. If they're under the influence, they're under the influence, and we go from that point. There's not a whole lot of data out there right now regarding marijuana and DUI arrests. If you actually go to, I believe it's the NHTSA, National Highway Safety Administration website, in 2016, I believe it was, the state of Washington did do some research, but it was very limited. And the one thing that came out of it was basically the state of Washington said that absolutely more research needed to be done. But the legalization, if you wish, the legalization of marijuana hasn't dramatically increased the use of marijuana. It isn't like people who used marijuana 20 years ago all of a sudden are saying, oh, it's legal now, let me go back to it. They quit using marijuana 20 years ago. So hopefully that answers your question.
Yes, thank you so much. All right, and this next question is for the folks at Hamilton County. Have you come across any conflicts of interest or differences of opinion amongst your coalition members? And if so, what were they and how did you overcome them?
There's always going to be, that's a pretty broad question, but particularly I think about the use of medication-assisted treatment and what it means to provide treatment, receive treatment services, and what recovery looks like. We still have a lot of education and work to do in many of our communities with regard to medication-assisted treatment being the model treatment for people suffering from an opioid use disorder. And just because they need that medication to help maintain their recovery doesn't mean that they are not a person actively in recovery.
And to follow up on that, there are some ideological differences, but not necessarily many, especially if you have the group that we have. Where we're finding some of the issues is from data, and some of it is certain groups have certain policies and laws they have to follow. So treatment has certain things when it comes to HIPAA, or there was a federal law on how many people that could have a treatment, or what data they could share. So the way we overcome some of that is from the law enforcement side, our stuff is public information. So we were able to use, the health department is able to use some of our 911 dispatches to get over some of that. And then for some of the stuff, we have to work with state and federal legislators to try to overcome some of the either the state or the federal regulations that are involved. And that's why it's important to have those folks on your coalition, like your state legislators. Senator Portman, Senator Brown's office have been very active with the coalition so that we can identify those problems. A lot of these groups, when you're sitting across the table, you go, why can't you do this? And then when they go, law X, law Y, law Z says we can't do this, policy says we can't do this, then you start understanding that it's not ideological, it's more of a policy issue that we need to work on. So those were some of the hurdles and how we overcame a couple of them.
Rebecca, this is Kevin from Beaverton. Can I chime in for 1 second on MAT?
Absolutely.
Best practices says medically assisted treatment is absolutely a best practice. First off, if you want to use any kind of federal grant money, any kind of grant money that's tied into federal government, state government, you have to be open to medical assisted treatment. And the idea is someone that's going in and getting Suboxone, methadone to get off of opioid habit, addiction, they're going through a process and going to a doctor and proving to that doctor that they have this problem that needs to be addressed. And if you don't address it with a lot of these individuals with medically assisted treatment, they're going to go right back out into the street and they're going to get whatever substance they can get. That's continuing to keep this problem going versus going and getting some Suboxone or methadone and trying a different approach to change their behaviors. So.
From a judge perspective, I believe it is unethical to bar any sort of MAT. If you're using that as a screening criteria to not allow folks into programs because they're on MIT, I view that as unethical. To me, that's strictly a medical decision that should be done between a person and a doctor. And again, as Kevin said, it is a best practice.
Thank you both for sharing. I have another question. I think this one can probably be answered by both programs. Assuming that both programs have success stories of individuals who have come sort of through the end of the program, have you found a way to involve them either with present B-SOBR participants or found a way to involve those individuals in your coalition?
I'll start in Beaverton. We absolutely reach out continually to these individuals, to graduates, to come back, share their story, their success. Sadly, with addiction, there's a whole lot of stigma there, and it's difficult for a lot of people to raise their hand and want to volunteer to come back in and openly say, hey, I'm an addict in recovery. But what we have found is those individuals, there's some that do it a little bit more than others, absolutely, but they're difficult to find, and when we find them, we want to hang on to them and support their recovery as best we can.
We rely very heavily on our recovery community to do the work that we do successfully here in our region. The quick response teams, which are a pre-arrest diversion model, all have participants who are in recovery. We have in Ohio, Kentucky, and Indiana certified recovery support programs. So the importance of having somebody in recovery is heavily valued as a key to the successful work that we do, maintaining recovery, diverting people from the criminal justice system. And we also see that they play a role in some of the prevention work that we're doing with regard to education and addressing stigma within the community. So we do rely very heavily on our recovery community to be engaged in the work that we're doing successfully.
And they are an active members of the coalition. They are peer mentors, often used to help us get people into, like Sonia was saying, into the treatment. They also work on the stigma. They do speaking engagements, often with the coalition and community groups that we go out to. And they are part of, like Interact for Health is now working on a campaign. They are also advisors to that and give us advice on what should be said, what kind of wording, where we should go as far as what we should be pointing out as far as recovery. Actually, we have something that's called first responder fatigue in this area. And it's not necessarily just first responders just being tired. It's more of not feeling like they're helpful because of the number of overdoses. And it was actually those in recovery within the coalition and working with other treatment programs that started a program going out to first responders and talking about how they were saved by Narcan, maybe 2, 3. I've heard stories of 4 times someone saved by Narcan, and going out to the first responders and thanking them, which then helps ease some of that first responder fatigue, because it allows that first responder to know that they helped someone to recover and now their life's back on track. So we use them very heavily. They're very active members of the coalition. And as a matter of fact, you can't do it without people in recovery.
That's great to hear. Those success stories are very powerful, and it's encouraging to hear that both programs are utilizing them to your best abilities. Hamilton, I have another question here for you. You mentioned the importance of getting the business community involved in the coalition. Can you talk a little bit about their role in that coalition?
Well, when we originally approached them, obviously this takes a lot of money, and when you're talking about government, I don't care pretty much what level you're on, there's always financial issues that go along with it. So we first approached them kind of wanting to help out with financing, which was a little bit challenging back in 2015 or so when we first started seeing this really rise out, this epidemic. But what we're seeing is often the business community that's working on solutions. One of the programs that we're very excited about is Cincinnati Bell, which is the local kind of phone company, actually has started a program, and Sonia talked about core data. They're working on a texting platform, and they're working in smart region, what they call smart regions. So it's free Wi-Fi within certain areas of the city of Cincinnati. They have a texting platform that's going to use artificial intelligence that will allow someone to log into that free Wi-Fi. So if I'm a family member, if I'm a user, if I'm someone looking for education or help with addiction, I can sit on my phone connecting to that free Wi-Fi that's provided by Cincinnati Bell, get on their platform and say, I need help. My son is using heroin. Where do I get help? Automatically, artificial intelligence will start communicating with that person. Do you need 911? Do you need treatment? Do you have Medicaid? Do you need help with the insurance? So it'll give a list of things, resources right off the bat, and then connect them to a live person if they need to, or connect them directly to treatment, along with having access to a website that updates our available spaces within treatment within the region every single day. So they would have access to that also. So basically what's going on is Cincinnati Bell said, instead of the community coming to you, the system, wanting to get help and trying to find it, why don't you take the help to them? So that is an incredible program, and for Cincinnati Bell to step up and work on that is tremendous, and we actually think it'll be something that'll be able to go nationwide. So that's where the business community comes in. They have technology, they have research, they have data, and they move obviously quicker than what we do in government. As a matter of fact, Cincinnati Bell's been kind of honest, because once they got involved in the government, they're all kind of slowed down, so they get calls every day. Hey, when's this thing launching? But they're able to do some things that we're not able to do, and they obviously have that vision and the people that can do it. So that's where business can really help you. Also from the stigma side, if you can get business to even be part of your coalition and say, you know what, we're partnering with you. These are people in our community. And I'll give you the example of the 3 businesses on this, that we have that'll hire people. One's Amazon, and one's a local Cincinnati company that's been here for over a century. And they're hiring these people. That's significant for us, because then we can go to people and say, we have the help here. We just want to get you in there. We have these people that support you. And it really changes the discussion and allows for more people to get involved. If you get the business community involved, That's us. That's the people who go to work every day. That's our neighbors. That's our neighborhood. That changes the whole image of stigma, and it changes our discussion and how we deal and deal with addiction.
Great. That sounds like a wonderful participants to have in the coalition, and a huge get to get them to be involved.
Absolutely.
I think we're going to wrap up here soon, but I just wanted to give both programs an opportunity to share sort of parting thoughts, maybe your program's next steps or any growth or improvement that you're hoping to see in the next year or so. Beaverton, let's start with you guys.
So we're looking at expanding our peer support. I know that was a question earlier, but we don't have a peer support on our multidisciplinary team, so we recently received grant money specifically to do that. So we're looking to do that. We're also looking to add a some cultural competency to our program. We have approximately 6 or 7 Spanish-speaking participants, so we want to make sure that their access to the system is equal to their English-speaking counterparts. And lastly, we want to begin a mental health, a similar mental health specialty court to address the mental health needs of our defendants.
Great. Thank you for sharing.
Yeah, on the Hamilton County side, what we're working on is we've got the front end laid. We have the collaborations set in place. We're saving lives with Narcan, getting people into treatment, but now can we work towards that middle of getting into long-term care, getting some more people on board to make it more of a view of the medical health side? And can we work on that recovery with housing, with the peer mentors, with recovery, re-entry? Can we make sure that we keep people off of addiction, or it may be something that they're on medically assisted treatment for a period of time? Can we make sure they have the support they need? In other words, can we close some of those gaps to make sure people don't fall through the system? Can we make sure we help them in that recovery, get them back into society, get them back with their families, and get them back to jobs? And that's what we're working on, is that back end side to connect it all together.
We're also talking about how we can become more engaged in prevention along the lines particularly of trauma-informed care. We have not given the attention needed to children in our communities who are in homes where addiction resides, or they've witnessed an overdose in their home among a family member. So we're trying to begin discussions with regard to trauma-informed care and how we serve the children who are directly impacted by addiction.
That all sounds great. Wonderful next steps going on with both programs. I just really want to thank all of our presenters, most importantly for the work that you're doing in your communities to address addiction. And secondly, for taking time away from that important work to join us on today's webinar and to share that with other communities who might be struggling with similar issues. So thank you so much for your time and your expertise in sharing that with us here today. Really appreciate it. For those of you on the call, we will be sending out a follow-up email that will have these slides as well as a recording of today's webinar. You will also see a brief survey which will help us to know how the webinar went and any suggestions for future webinars. Speaking of future webinars, the next one will be February 13th, and we will be discussing leveraging education to achieve equity and improve futures. So we hope that you can all join us on that. And that wraps up today's webinar, and we hope to hear from all of you again soon.
Rebecca, this is Kevin in Beaverton. Thank you very much, and I just want to share, if anyone has any more questions about our program, absolutely feel free to email me.
Great, thanks, Kevin. I will include the presenters' email addresses in that follow-up email as well, so if you have any direct questions about a program, you can reach out to one of the presenters.
Are we off?